I don't want to see your Coke, Steve Riley.
All right, good afternoon. We will go ahead and get started. I'd like to just welcome everyone to the first Health and Family Services meeting of the regular session. And thank you to all of our presenters today. We I think I'll go ahead and call the meeting to order. And Secretary, please take the roll.
Representative Bentley. Representative Bowling.
Here.
And I'm sorry, I'm going to interrupt. If you're remote, please tell us whether you are in your office or on campus, and only those on campus are permitted to vote. So, sorry.
Representative Bray.
Present in the room.
Representative Birch. Representative Dotson.
Present in the room.
When they get ready to vote, just let me know, okay? Because I'm a yes on everything.
Excuse me. Representative Elliott. Representative Fleming. Representative Frazier Gordon.
Present in the room.
Representative Marzian.
Present in my office.
Thank you. Representative Gibbons Prunty.
Present on campus.
Representative Rayburn.
Present in the room.
Representative Raymond. Representative Riley.
Present in the annex.
Thank you. Representative Sharp. Representative Sheldon.
Present in the room.
Representative Tate. Representative Weber. Representative Westrom. Representative Wilner.
Here in the room.
Thank you. Chairwoman Mosier.
I am here in the room.
Wonderful. Thank you.
Okay. We have a quorum established to do business, and we have 4 bills that we will be taking up today. And I just want to remind the members who are on remotely, please mute yourself unless you are speaking. And the first bill, well, actually, I think what I'm going to do is take up the regs first, because we do have some folks online to answer questions should we need to do so. All of the regulations, administrative regs, were sent out to members, And we do have one reg with an agency amendment. DPH has an amendment which was asked for by the hospitals regarding duplicative COVID reporting. And that was sent out to members, and I will ask if there are any questions. Oh, this is, my apologies, 902 KAR 002020, reportable disease surveillance. Okay. All right, we'll see no questions. I will ask for a voice vote. Do we need a motion? So I will entertain a motion. And do we have a motion? Motion and a second, thank you. All in favor, please say aye.
Aye.
Any opposed? Okay. All right. And as far as the other regs, I will consider those to have been reviewed, if there are no questions. Okay. Thank you very much. The first bill that we'll take up is House Bill 61. We have with us Representative Johnson, and I will just have you introduce yourself for the record, and please proceed.
Thank you, Madam Chairwoman. Thank you, members of the committee. My name is DJ Johnson, State Representative for the 13th District, Owensboro-Davis County area. And if technology has not failed us, I'm being joined online by Sarah Fair, who's the Director of Operations for one of our local orthopedic clinics in Owensboro, but I do not know if she's on, so if you're there, let me know.
I'm here.
All right. So, Sarah, would you please introduce yourself and your position?
Sure. I'm Sarah Fair. I'm the Director of Operations for Advanced Center for Orthopedics and Sports Medicine in Owensboro. We have 8 orthopedic surgeons. We currently employ, do you want me to give that information now? Sorry.
That's fine, yeah.
Yep. We employ 1 limited X-ray machine operator licensee. She has held her Kentucky license since 1993. It was 29 years to the date on the 11th. She has been employed by Advanced for 16 years. And she would love to continue working there and would love to retire from Advanced if possible.
So thank you, Sarah. Again, thank you for the committee for allowing me to come before you. I am speaking today on House Bill 61, which is an act relating to limited X-ray technicians. And I will first give a little bit of a background, but I will say up front that the reason that I'm here today is for that lady that's working in Owensboro as a limited X-ray technician and all the other limited X-ray technicians currently employed across the state of Kentucky. For years, medical practices have employed school-trained X-ray technicians to take X-rays. For some time, X-rays were the state-of-the-art radiographic procedure. As medicine and technology have progressed, there are now more and different radiographic options used by medical practitioners. These new technologies require additional training and certifications. However, the basic X-ray is still a valuable tool and still used extensively today. And I realize I'm preaching to the choir here, but I need to set the background just a little bit. Briefly, the medical profession was concerned that X-ray technicians who are not trained and qualified in other radiological equipment might be allowed to operate that equipment. KRS 311B.020 was promulgated to keep this from happening. It requires that a limited X-ray technician, previously an X-ray technician, cannot operate the X-ray equipment for which they are trained to operate in a facility where advanced radiographic procedures are also conducted. The unintended consequences is that there are highly trained and qualified limited X-ray technicians who have been doing their job for years in a given practice. Per the above-mentioned KRS, medical practitioners have a dilemma at this point. They must either establish a separate facility for each of these levels of radiological procedures, or they may have to fire that same X-ray technician who has been working at that practice possibly for years. And in this case, that's exactly what the situation is. HB 61 does one simple thing. It grandfathers in limited X-ray technicians who have been performing those duties prior to the addition of these newer technologies. HB 61 does not in any way authorize or encourage limited X-ray technicians to perform any procedures for which they are not trained and qualified. And then one final note before I open up to any questions. This bill is eventually going to actually grandfather itself out of existence, because what this will be doing is providing that protection for X-ray technicians who have been there for years and are eventually going to retire. And now, as I'm sure every one of you know on this committee, the training for radiological technologies includes the X-ray machine and beyond, and there are no limited X-ray technician training courses available anymore. So this will eventually become an obsolete regulation, but in the meantime, I feel it is very important for us to protect these employees who've been doing a great job for years and still do. With that, Madam Chairwoman, I'll answer any questions the committee might have.
Okay, thank you. I appreciate your brevity and your clear explanation of a topic that somehow was confusing and to a lot of members, but I think you were pretty clear. And are there any questions?
Second.
Okay. We have a motion on the bill and a second. Any discussion? All right, seeing none, we will go ahead and take the roll.
Representative Bentley, Representative Bowling, Representative Bray,
Yes.
Representative Birch, Representative Dotson,
Yes.
Representative Elliott, Representative Fleming,
Aye.
Representative Frazier Gordon,
Yes.
Representative Marzian,
Yes.
Representative Gibbons Prunty,
Yes.
Representative Rayburn,
Yes.
Representative Raymond.
Yes, I'm here in my annex office today and I vote yes.
Thank you. Representative Riley,
Yes.
Representative Sharp,
Did you get that?
Representative
Yes.
Sheldon,
Yes.
Yeah, Miller got it.
Representative Tate, Representative Weber, Representative Westrom, Representative Wilner,
Yes.
Chairwoman Mosier.
Yes, and we do have two members who are in other committees and would probably like to record a vote.
I'd like to report a vote, a yes vote on House Bill 61.
Thank you. Representative Tate,
I would like to record a yes vote for House Bill 61.
thank you very much.
Thank you.
All right, the motion passes, the bill passes, and we'll likely do the same on the House floor. Thank you very much.
Thank you, Madam Chairwoman. I would like to thank Ms. Farrer for being taking some time to join us today as well. Thank you very
Yes,
much, Sarah.
Thank you very much.
Thank you.
Thank you all for your time.
Thank you. Okay, next we will take up House Bill 127, an act relating to court-ordered mental health treatment. And Representative Fleming, if you will introduce yourself for the record and have your guests do the same. And I know that we do have a committee sub.
Thank you, Madam Chair. I do have a committee sub. I'd like to go ahead and make a motion for the committee sub, please.
Okay, so I'll entertain a motion on the sub. We need a motion on the sub. Thank you. A motion and a second. Thank you. All right. All in favor?
Just change one word. It's not a
Aye.
big deal.
Any opposed? Okay.
It
Thank you.
changes the
Please
word from,
proceed.
Injury. Thank you, Madam Chair. I just wanted to first start out by saying nothing like being a thorn between two roses. So I'm going to try to go through this the best way I can. But I just wanted to compliment the lady on my left, which you're right, Representative Wilner, who's been very instrumental in helping me out on quite a few different aspects. This is just one of them. And then on my right and your left is Judge Stephanie Burke from Jefferson County. She's a judge there who's been a really strong advocate and instigator in terms of really having Tim's Law come into fruition. So what I'd like to do is just spend just about a minute or two, just give you a real quick background if you're not familiar with Tim's Law, and then show and talk about what the bill does in very brief format. Then I'll have Representative Wilner make a comment, and then Judge Burke will go through and give you a little more details on what the bill does, and we'll go from that. This past summer, we went through a very laborious process, a very productive process with the severe mental health. And one of the recommendations that came out is what we need to do with Tim's Law. And with Tim's Law, if you're not familiar with it, it passed several years ago. It basically authorized state district courts to order assisted outpatient treatment, or AOT, for individuals who have been diagnosed with severe mental illness and are unlikely to seek treatment on a voluntary basis. This is a great partnership between the courts, the clients, and the healthcare system to try to get individuals to have a little better quality of life in terms of managing the meds and so forth. And Judge Burke has been very instrumental in getting this going in Jefferson County, and we want to try to expand this further throughout the whole state. I wanted to just briefly cover exactly what this bill does. First of all, it clarifies some language, which the judge will go over and talk about in terms of reports and look at clarifying some language. The other one is basically trying to roll this out more, and based on a grant that was submitted some time ago to get this program going, there's a significant number of individuals that can really benefit from the assistant outpatient treatment program that we're finding, and I understand the judges throughout the state support this particular initiative. So with that, I'm going to stop for a moment and have Representative Wilner make some comments, and then we'll go from there.
Thank you, Representative Fleming, and thank you, Chair Moser and members of the committee for this opportunity to speak about this really good bipartisan bill that came out of the work of the Severe Mental Illness Task Force that met over the interim. This bill would amend Tim's Law, or court-ordered assistant outpatient treatment, to potentially include more individuals with diagnosed severe mental illness to be eligible while still keeping very strict guidelines in place, guardrails. There should be a high bar for court-ordered treatment of any kind, and this bill preserves that high bar. Tim's Law provides an evidence-based approach that improves outcomes for people with severe mental illness, reduces anxiety and stress for their loved one, and saves money. Assisted outpatient treatment has been shown to disrupt the cycle of involuntary hospitalizations, to houselessness and life on the streets, to arrests, to incarceration. The approach has the potential to allow more individuals to access treatment and to avoid law enforcement jails and emergency rooms, which is sadly too often the default community response to people with severe mental illness. We know from the experience of more than 40 other states that court-ordered assisted outpatient treatment works. These changes to the current law, recommended by Judge Burke and endorsed by the SMI task force, will remove barriers to allow more Kentuckians who've been diagnosed with severe mental illness to benefit from Tim's Law. And I'll just add that after passage of House Bill 127, the next step will be to assure that there's funding in place to take Tim's Law statewide. Thank you.
Microphone.
Thank you, Madam Chair. She'll go over a little more details about the bill and so forth, and then we'll entertain some questions.
Thank you, Madam Chair and members of the committee. Many of you have heard me speak on Tim's Law before, so I appreciate the opportunity to be here once again as we try to move forward with this opportunity to serve the seriously mentally ill population in Kentucky. This bill does two things. First of all, it provides a statutory cleanup to the current status of the bill. Presently, there are two critical defects in Kentucky's current legislation. First, the inconsistent use of the word examination leads to some unintended consequences, which I will explain, and it also sets the bill up for failure if it were to be reviewed by a higher court, particularly for its ambiguity, and secondly, because it creates some due process issues, which I will explain. First of all, the bill uses the word examination in two different ways. It uses it when speaking about the clinical evaluation or assessment of the respondent, who is the patient. It also uses the word examination when it pertains to the testimony being taken under oath, meaning the sworn examination by the court of the petitioner, who is the person taking out the petition against the respondent. When utilizing that word throughout the bill, kind of indiscriminately, it can be interpreted to have some unintended consequences. And the first of those is that the statute has a sentence which allows and permits the dispensing of the examination of the qualified mental health professional if a report outlining the respondent's clinical condition is filed at the time of the petition. That means that the case could go forward without any medical support. Clearly, that was not the intention of the drafters. One would conclude that the statute would allow that to proceed without any evidence, and clearly that could not be the intent. The intent of the drafters was to dispense with the taking of the sworn testimony of the qualified mental health professional in the event that they filed their evaluation of the respondent at the time they filed the petition, when they are in fact the petitioner. This must be cleared up. I have provided a very simple fix for that, and that is that you must call the evaluation of the respondent the evaluation, and you call the testimony taking the examination. And so that's a simple fix, and it eliminates the ambiguity. The second thing that it does is the current language in the bill has some due process issues created, because when writing the bill, there was a lot of cut and pasting. As you know, when writing bills and working on bills, language is often changed. And during that time, there was a sentence in the bill which states that the qualified mental health professional's report must be sent to the court within 72 hours. It does not say 72 hours from when. 72 hours from what? That cannot be determined or assessed from a clear reading of the bill. That sets the bill up for challenge, in a valid challenge. The language which we have provided makes that very clear, that it's 72 hours from filing of the petition. That's consistent with other 202A provisions, and it should be changed to that to make it clear and unambiguous. The next thing that it does is the bill allows a situation in its current form where an individual, when it talks about the setting of the hearing, it is very ambiguous in that it says that the hearing is to be set in 6 days. It's not clear if 6 days from when. And it talks about setting it 6 days from the date of the examination, which it means the evaluation, the clinical evaluation of the patient. If the qualified mental health professional is permitted to file the evaluation 5 days before they file the petition, that would allow you to schedule your hearing the day after. Clearly, it was not the intent of the drafters to allow there to be 1 day notice to all parties of a hearing. That clearly was an unintended consequence of the language, and that needs to be changed to be consistent with all other provisions in 202A, and to change the language to say that it is 6 days from the filing of the petition, just like in a 202A for hospitalization. This is sheerly a cleanup of the language to rectify those due process issues created by the current language. It's a simple fix, and so that's what the current draft of 127 does. The second thing the bill does is that it amends their criteria of the statute to expand eligibility to not just persons who are repeatedly hospitalized, but also to persons whose conduct and behavior and their mental illness lead to them being repeatedly arrested and incarcerated. We know that AOT is intended to reduce hospitalization and arrest and incarceration, but the way our bill currently reads, it does not do that. It only looks to hospitalization history. It does not look to the other behaviors that would lead to arrest and incarceration. We know that our courts are bogged down with individuals who are tied up in the system by repeated arrests in long-term incarceration because this population spends more time in custody than persons without serious mental illness due to the necessity of having competency evaluations performed on them once they are charged with crime. This allows them to become eligible for AOT and gives the courts and prosecutors a tool to utilize to avoid that practice. So this is a very humane way of dealing with this population. It's fiscally responsible. It relieves the burden on many different parts of the system, from law enforcement to the court system, to hospitals, to the mental health system. It's just the smart thing to do, and it's the more humane thing to do. And it's a very simple fix. I have Brian Stutton, who is on the screen. Brian is the policy coordinator and director for the Treatment Advocacy Center. He's the foremost expert in the country on AOT. Brian's prepared to talk about the last portion of the bill, which eliminates the portion of our statute which requires a diagnosis of anosognosia. And he can explain to you why that should be eliminated.
Good morning. I'm not sure if I can speak without being recognized by the sponsor or the chair, but so I'll happily go forward.
Please,
sounds like
please do.
Okay, sure. Thank you. Good morning, Madam Chair, members of the committee. As I said, my name is Brian Stetton. I'm the policy director for a national organization, the Treatment Advocacy Center, that works to promote this concept of AOT nationally. We're proud to be working with the state of Kentucky as grantee under the SAMHSA AOT funding program as a technical assistance provider. And just want to say a little about, as Judge Burke mentioned, the part of the bill that removes from the criteria for finding someone eligible for AOT that there be a finding of anosognosia. Anosognosia is a neurological condition in which a person is unable to recognize their own illness, no matter how painfully obvious it is to everyone around that person. Information is simply not reaching the right part of the brain for the individual such that they can recognize they have an illness and a need for treatment. And it has a lot to do with why people are often caught in this revolving door. They reject treatment because they don't believe they're in need of it. Sometimes this is mistaken for denial. It's actually a much more scientifically rooted condition. Denial is a kind of a universal defense mechanism that we all practice from time to time, whereas someone with anosognosia is actually experiencing dysfunction of their brain, which is preventing the information from reaching them. And as much as I appreciate the fact that the Kentucky law acknowledges anosognosia, because as an organization, we are working so hard to increase awareness of this as part of the explanation of the problem here, it really has been a hindrance to have it in the law as a requirement that we find anosognosia for a couple of reasons. First of all, anosognosia is not itself a mental illness. It's a corollary of severe mental illness for many folks, by no means all. But it's very often not formally diagnosed because it's not an illness itself. And so many people who would be recognized with this condition are never actually diagnosed that way, such that such proof could be presented to the court. Another real problem with having this in the law is that there are many individuals who have difficulty maintaining insight into their illness in a way that kind of waxes and wanes, comes and goes, whereas someone with anosognosia has a fixed inability to recognize their illness. And we want to make sure that this law is applicable to folks who may lack insight when they're in a manic phase, for example, but are at other times able to get it back and wouldn't be actually found to have anosognosia. So I think it's going to make the law much more applicable to the population we're trying to serve here, to simply take that out of the criteria and focus the court's inquiry on a person's inability, for whatever reason, to maintain consistent engagement with treatment. Thank you.
Okay.
All
Thank
right.
you.
There's one additional thing that we wanted to add is that I think it's important to realize that this section of the population is only 1.4% of all Kentuckians fall in the SMI category. And the persons who actually make it to the system where we would see them for eligibility purposes is probably only about 25 to 30% of that. So this is a very small number of individuals who come in contact with the system in a way that we would be able to serve them under AOT. So we're talking about a very small number of individuals statewide.
And Madam Chair, I'll wrap up, and that is, as the judge said, this is a very small population we're dealing with, but I want to stress and make sure you're quite aware this is a very high cost process. And we're going to be looking at down the road some measures in terms of putting something into the budget in order to help expand this to save, which I think be a significant amount of money for Medicaid. But overriding that, from my point of view, and I think these two fine public servants next to me, it's a system of care that we're looking at. We're trying to help these folks to get them back in society, to manage their lives a whole lot better. So this is more of a moral obligation I think we need to apply to help out these individuals who are least among us, to make sure they're elevated so they can function a whole lot better in society. So with that, Madam Chair, thank you very much to you all in the committee. If there's any questions, we'd be more than happy to entertain them.
We have a motion and a second. I just want to take a minute to thank you, Representative Fleming and Representative Wilner, for working on this. And of course, Judge Burke, it's always great to see you. I so appreciate your work in this area. I know that you're really passionate about this, and it's very helpful to us as policymakers to have someone so interested in getting this right and really addressing this population. This is a population that we often forget about, and they don't get the care that they need, and this really strengthens the ability of individuals to get the care that they need. So thank you so much for your work on this. And we do have one question. Representative Elliott.
Thank you, Madam Chairman. Thank you, Representative Fleming, Representative Wilner, and Judge. I noticed that the word examine has been stricken throughout the bill, as you alluded to. When we use the term evaluate, does that change?
Representative Elliott, is your microphone on?
It is, maybe I'm not close enough to it.
Okay,
I'm sorry.
thank you so much.
The term evaluate, does that change whether or not the respondent is examined in person?
No, they
Okay.
have to be examined in person.
Okay, so that doesn't change the approach. Okay,
No.
that's all I have. Thank you.
Okay, thank you. Seeing no further discussion or any further questions, I think we'll go ahead and take a vote. We do have a motion and a second. We are voting on House Bill 127 as amended by House Committee Sub 1. Secretary, please take the roll.
Representative Bentley, Representative Bowling, Representative Bray,
Yes.
Representative Birch, Representative Dotson,
Yes.
Representative Elliott, Representative Fleming,
Aye.
Representative Frazier Gordon,
Yes.
Representative Marzian,
Yes.
Representative Gibbons Prunty,
Yes.
Representative Rayburn,
Yes.
Representative Raymond,
Yes.
Representative Riley,
Yes.
Representative Sharp, Representative Sheldon,
Yes.
Representative Tate, Representative Weber,
Yes.
Representative Westrom, Representative Wilner,
Yes.
Chairwoman Mosier.
Yes.
Thank you.
Okay. House Bill 127, as amended by House Committee Sub 1, passes with favorable expression, and the same should pass on the House. And we do have some members who will need to record a vote when they come back. So, okay, and here they are. Would you like to record a vote?
I would like to record a vote. Yes, vote for 127. Thank you.
Thank you so much.
Thank you, Madam Chair, for your consideration, and thank you, committee, for passing this measure.
Thank you all for your work.
Thank you all.
Appreciate it. Thank you. Okay, I will make my way to the table, and Representative Weber will take my place for a few minutes, and we will be presenting House Bill 237 to begin.
Madam Chair, may I record a yes vote on House Bill 237?
You mean House Bill 127 as amended?
127.
Yes, the committee said. Thank you.
We are now taking up House Bill 237. Representative Mosier, we know you. If you'll introduce yourself, and Representative Wilner as well, and then after you've done that, you may begin your presentation on the bill.
Thank you so much. I am State Representative Kim Mosier, representing the 64th District.
State Representative Lisa Wilner, representing House District 35.
I thank you for giving us the opportunity to discuss this important measure. As we know, we have a shortage of psychologists and mental health workers here in the state of Kentucky. We have discovered an issue in our statute dealing with licensure as it relates to the educational opportunities that we currently have in the state of Kentucky. And all this does is allows applicants who are pursuing their doctorate in psychology that have the equivalent education for a master's degree to practice as a licensed psychological associate. This change would increase the number of practitioners and hopefully keep those practitioners in the state of Kentucky. And that's just a brief overview, and I will invite my colleague to describe these changes a little more fully. And I know that Sheila Schuster is online with us, and thank you for being here. Please introduce yourself and
Thank you. Yep, I'm Lisa Wilner, and I see that the Executive Director of the Kentucky Psychological Association, Dr. Eric Russ, is with us as well, and I think he'll be available to answer any questions if there are any. Thank you, Chairman Moser, for this. And thank you, committee, for hearing this. There's been a licensing law in Kentucky for psychologists since 1948, and from time to time there have been updates to the psychology licensing law. The last one was well over a decade ago, and this bill would make two small tweaks that came to us actually at the request of the members of the Kentucky Psychological Association. I'm going to start on page 3, lines 19 through 22. And as Representative Moser said, this change is to remove a barrier to licensure and to help attract and retain psychology interns to Kentucky. So psychology interns are doctoral students who have completed 4 to 5 years of postgraduate coursework, plus about 1,800 hours of clinical practicum experience where they provided psychological services under the supervision of a licensed psychologist. So these are experienced, well-educated mental health providers who then must complete another 1,800 hours of supervised clinical hours and a pre-doctoral internship in order to become licensed psychologists. So currently in Kentucky, an individual with a master's degree in psychology who's met other training requirements can become licensed as a psychological associate. Kentucky is one of only a handful of states that allows licensure at the master's level, and that's a very good thing. These LPAs, licensed psychological associates, practice under the supervision of a doctoral level licensed psychologist, and they're eligible for Medicaid and other insurance reimbursement for providing services. And all of that is working very well. The problem that we run into is that some psychology doctoral programs do not award a master's degree along the way. So these interns have the same experience, the same training as those from other programs, but despite having all this education and experience, they're not currently eligible to become licensed psychological associates under current
Motion on the bill.
licensing law,
Yep.
and are
Second.
therefore not eligible for insurance reimbursement for services. So this bill, what it would do would be to authorize the Kentucky Board of Examiners of Psychology to license individuals whose academic qualifications meet those of the psychological associate if those individuals are practicing as interns in a pre-doctoral internship program that meets the board's criteria.
Yeah, we do have a motion and a second on the bill.
Fantastic.
Do we have any questions from members of the committee? Seeing we have no questions, please call the roll.
Representative Bowling? Representative Bentley? Representative Bowling? Representative Bray?
Yes.
Representative Birch? Representative Dotson?
Yes.
Representative Elliott? Representative Fleming?
Aye.
Representative Frazier Gordon?
Yes.
Representative Marzian?
Yes.
Representative Gibbons Prunty?
Yes.
Representative Rayburn?
Yes.
Representative Raymond?
Yes.
Representative Riley?
Yes.
Representative Sharp? Representative Sheldon?
Yes.
Representative Tate? Representative Weber?
Yes.
Representative Westrom? Representative Wilner?
Yes.
Chairwoman Mosier?
Yes.
Wonderful.
The bill passes favorably and now moves to the House floor. Congratulations.
Thank you so much. And thank you, Representative Wilner. Thank you, Sheila. And thank you, Eric, for being here and for your work on this bill. And
we'll now move to a second bill sponsored by Representative Mosier. Today, House Joint Resolution 28. Representative Mosier, if you'll again introduce yourself for the record on this resolution, and after you've done that, you may begin your presentation.
Okay, thank you, Mr. Chair, and thank you, committee. I am Representative Kim Mosier, representing the 64th District, and I just appreciate the opportunity to talk a little bit about this House Joint Resolution. I think first what I'll talk about is what the prescription digital therapeutics are that are referenced in this bill, because I think it's a really interesting new technology that we're likely to start seeing more and more of. This technology is an FDA-approved substance use disorder treatment